Hello everyone. So today we will talk about the topic diabetes mellitus. It is one of the very important and crucial topic. So basically diabetes refers to a group of common metabolic disorders that share the phenotype of hyperglycemia. The basic problem in diabetes is hyperglycemia. In the metabolic dysregulation associated with diabetes causes secondary pathophysiology changes in multiple organ systems that impose a tremendous burden on the individual with diabetes and on the healthcare system. The basic problem in diabetes is not just hyperglycemia because the symptoms that patients have due to hyperglycemia are just minimal, that is polyphagia, polyuria, and polydipsia. But the chronic increase in blood sugar level leads to pathophysiologic changes in multiple organ systems, and this leads to multi-organ failure in the long run, and that is the main cause of our cancer. For example, it can lead to coronary artery disease, it can lead to nephropathy, it can lead to retinopathy, it can lead to neuropathy. So that is our main cause of concern. Now the etiological classification of diabetes mellitus. This table is being taken from Harrison. First type is type 1 diabetes mellitus. We have already know that this is immune-mediated beta cell destruction, usually leading to absolute insulin deficiency. Okay. So that's why we say na, that in type 1 diabetes, the treatment is insulin only because the OHs don't work here because there is absolute insulin deficiency. We also used to call it as insulin-dependent diabetes mellitus, but this term is obsolete now. Then we have type 2 diabetes. It may range from predominantly insulin resistance with relative insulin deficiency to a predominantly insulin secretory defect with insulin resistance. And it is the most common type of diabetes. And it is having polygenic inheritance. Clear? Then we have specific types of diabetes in which one is MODY, that is maturity onset diabetes of young, and it is having a monogenic inheritance. That is, if someone is having MODY or maturity onset diabetes of young, then there is a high chance that one of their parents must be having that. Okay? And it is having an autosomal dominant mode of inheritance. So in maturity onset diabetes of young, we have many types from MODY 1, 2, 3, etc. And in each one of them, there is a specific defect. So first one is hepatocyte nuclear transcription factor 4 alpha defect. Then we can have glucokinase defect. We can have HNF1 alpha defect. Then we can have insulin promoter factor 1 or HNF1 beta or neuro D1 or other pancreatic islet regulator proteins such as these. Okay. Then we can have defect in insulin only, which can lead to permanent neonatal diabetes. Then we can have defect in subunits of ATP sensitive potassium channels, which can lead to permanent neonatal diabetes, or we can have defect in mitochondrial DNA. Okay. So all these are type of defects that are found in MODY. Then we can have transient neonatal diabetes. Then we can have diseases of the exocrine pancreas presenting as diabetes like in pancreatitis, in pancreatectomy, in neoplasia, in cystic fibrosis, in hemochromatosis, where there is deposition of iron on the beta cells. Then we can have fibrocalculous pancreatopathy. Then we can have mutations in carboxyl ester lipase. Then we can have genetic defect in insulin action, like in these syndromes, which can lead to diabetes. Then we can have endocrinopathies, like in acromegaly, in which there is hypersecretion of the growth hormone, and as we all know that growth hormone leads to hyperglycemia. Then we have Cushing syndrome, in which there is more secretion of glucocorticoids, leading to hyperglycemia, or there is a glaucogonoma or pheochromocytoma, hyperthyroidism, somatostatinoma, and aldosteronoma. Okay. Then drugs or chemical induced diabetes like glucocorticoids, which increase blood sugar level, calcineurin and mTOR inhibitors, and other drugs. Okay. Then infections can lead to beta cell destruction and can lead to diabetes like congenital rubella, cytomegalovirus, Coxsackie virus. Then uncommon forms of immune mediated diabetes Then other genetic syndromes sometimes associated with diabetes like Wolfram syndrome, Down syndrome, Klinefelter syndrome, etc. The fourth one is gestational diabetes mellitus. Clear? Now, what are the basic symptoms of diabetes? So, the first symptom is polyuria. Then we can have polyphagia and polydipsia. Clear? And the patient is also having unexplained weight loss. Clear? These are the symptoms of hyperglycemia or diabetes. The cause of polyuria is since there is a limit to reabsorption of glucose from the PCT. So when the blood glucose levels rises above a particular limit, then that above the limit glucose won't be reabsorbed. So it would lead to glycosuria, and glycosuria due to osmotic diuresis leads to polyuria. Okay? Then this is a diagram showing the release of insulin from the beta cells. So what happens that there are ATP sensitive potassium channels here. Okay, and this is glucose. Suppose when you eat something, this glucose enters the beta islet cells. With the help of glucokinase, it gets converted to glucose 6 phosphate, and then it enters glycolysis, and then there is a production of pyruvate. The ATP produced in this process inhibits this ATP sensitive potassium channels. Now, since this ATP sensitive potassium channel is inhibited, there is increase in potassium in the cell, leading to depolarization. This depolarization would now open voltage dependent calcium channel, leading to influx of calcium into the cell, and this lead to release of the secretory granules containing insulin. So this is how insulin is secreted. Now this ATP sensitive potassium channel also have this domain where the sulfonlyureas bind. Clear? Now diagnosis. So how to diagnose that a person is having diabetes? We have these three glucose level, that is normal glucose tolerance, then impaired glucose tolerance, and over diabetes. This impaired glucose tolerance is known as pre-diabetes. Okay. Now, if fasting plasma glucose is less than 100, okay, then this is normal glucose tolerance. If it is between 100 to 125, it is impaired glucose tolerance or pre-diabetic stage. Clear? And if it is more than 126, then it is diabetes. Clear? HbA1c, if less than 5.6%, it is normal glucose tolerance. If it is 5.7 to 6.4%, it is pre-diabetic stage. And if it is more than 6.5%, it is over diabetes mellitus. Then 2 are postprandial glucose. If it is less than 140, it is normal. Between 140 and 199, it is impaired glucose tolerance. If it is more than 200, it is over diabetes. And fourth criteria is symptoms of diabetes plus random blood glucose more than 200. Clear? Now, treatment of type 2 diabetes mellitus. As we all know that in type 1 diabetes mellitus, we can only give insulin and one drug, that is amylin analogues. Okay? So we will focus on treatment of type 2 diabetes, which includes both medical, nutritional therapy, OHS, and insulin. It includes all three. Clear? Now, treatment of type 2 diabetes. So it just not that we have to treat by drugs. There are a lot of things we should do that can prevent the complications. Okay. So these are the guidelines for ongoing comprehensive medical care for individual with diabetes. Okay. So it's not just that we have given the drugs, it's that we have to do a comprehensive medical care for diabetic individuals. First one is individualized glycemic goal and therapeutic plan. Okay. So we should have a glycemic goal and therapeutic plan that is individualized for each patient. Okay. Then the second thing is self-monitoring at individualized frequency of blood glucose. So the patient should be motivated to check his blood glucose by himself. Okay. And at individualized frequency. Then HbA1c testing should be done 2 to 4 times per year. Then lifestyle management should be done. Nutritional therapy should be there. Physical activity should be there. And psychosocial care should. Then there should be detection, prevention, or management of diabetes related complications. So we should have diabetes related eye examination annually or biannually. Then we should have diabetes related foot examination 1 to 2 times per year. Then we should have this diabetes related neuropathy examination. And we should have diabetes related kidney disease testing. Okay. Then the last part is manage or treat diabetes relevant conditions, including blood pressure, lipids. Consider antiplatelet therapy with low dose aspirin in patients having high risk of coronary artery disease. And since diabetic patients are more prone to infections, influenza, pneumococcal, and hepatitis B and coronavirus immunization should be done. So this is our comprehensive medical care for individuals with diabetes. Now, what should be our treatment goals for adults with diabetes? So this is the goal for non-pregnant adults, and then we have goal for older or high-risk adults. Okay. HbA1c in non-pregnant adults and low-risk adults should be less than 7%, while in high-risk adults or older people, the goal is less than 8%. Then preprandial capillary blood glucose, our target in non-pregnant adults is 80 to 130, while in older or high-risk adult is 90 to 140. Then postprandial, so it was preprandial, sorry. Then postprandial capillary blood glucose less than 180 in non-pregnant adults and less than 200 in high-risk adults. Then time in range, that is the time duration throughout which the blood glucose is in normal range should be more than 70% for non-pregnant adults and more than 50% for high-risk adults. The time duration during which it is less than 70 should be less than 4% in non-pregnant adults and less than 1% in high-risk adults because there is more chances of hypoglycemia in them. And glucose variability should be less than 36% in non-pregnant adults while less than 33% in high-risk adults. Clear? Now, this is a flow chart showing how to proceed in patient with type 2 diabetes mellitus. So suppose we have made a diagnosis of type 2 diabetes in a patient, then our next target is that we have to individualize glycemic goal. It is, we should know that what is our glycemic goal for this patient. Okay. Then we'll start with medical nutritional therapy, increase physical activity, weight loss, plus first line OHA, that is metformin. Okay. Then we'll reassess HbA1c after 3 to 6 months. If it is well under control, that is within our target, then it's quite good. Otherwise, we'll add second agent along with metformin. So combination therapy with metformin plus second agent. Then we'll again reassess HbA1c after 3 to 6 months. If it is well under control, then it is good. Otherwise, we have two options now. We can add combination therapy metformin plus two other agents, or we can have insulin plus metformin. And again, we'll reassess the HbA1c and titrate the insulin levels. Clear? Now, the important points in management of type 2 diabetes is that diet, lifestyle, exercise, and medication are important, but along with this, we have to treat associated conditions like dyslipidemia, hypertension, and obesity. And we should screen for complications like retinopathy, nephropathy, neuropathy, cardiovascular disease, and other complications. So this is our comprehensive care of type 2 diabetes. Now drugs. So in drugs, we have oral drugs, then we have two injectables, and then in the last insulin. So first of all, we'll discuss about oral drugs. In oral drugs, the first class is insulin secretagogues. That is, they increase insulin levels. And since they increase insulin level, they can lead to hypoglycemia. Yeah. So these are the only drugs OHs which can lead to hypoglycemia. Otherwise, rest of the OHs don't lead to hypoglycemia. They just reduce blood sugar level, but they don't do it below the level of 70. Clear? We have two class in this group, that is sulfonlyureas and meglitinides. Clear? Now, insulin secretagogues. I just wanted to say that other OHs other than secretagogues don't lead to hyperglycemia. Clear? It's not that they don't lead to blood sugar level below 70. They can get it beyond below 70 also, but there is no hypoglycemia. Clear? Now, insulin secretagogues, especially the longer acting ones, have the potential to cause hypoglycemia, especially in elderly individuals. Okay. Now, hypoglycemia is usually related to delayed meals, increased physical activity, alcohol intake, or renal insufficiency, which leads to increase in the half-life of these drugs. The first drug is sulfonlyureas. They act by inhibiting ATP-sensitive potassium channels. First generation sulfonlyureas, for example, chlorpropamide, tolazamide, and tolbutamide, have a longer half-life and a greater incidence of hypoglycemia and more frequent drug interactions. So they are no longer used. Second generation sulfonylureas like glimepiride, gliclazide, and glipizide have a more rapid onset of action and better coverage of the postprandial glucose rise, but the shorter half-life of some agent may require more than one dose. So currently we are just using second generation sulfonylureas like glimepiride, which is more commonly used than gliclazide and glipizide. Weight gain is a common side effect of sulfonylureas therapy, and it results from the increased insulin level and improvement in glycemic control. The second secretagogues is meglitinides. They also act by inhibiting ATP-sensitive potassium channels. Examples are repaglinide, netaglinide, and metaglinide. Because of their shorter half-life as compared to sulfonylureas, these agents are given immediately before each meal to reduce meal-related glucose increase. Then we have non-secretagogues, in which first and most important is biguanides, in which the prototype drug is metformin. And another drug in this class is fenformin. Yeah. So metformin is a representative of this class of agent, and it reduces hepatic glucose production and improves peripheral glucose utilization slightly. Yeah. And how does it does this? Is metformin activates AMP dependent protein kinase and enters cell through organic cation transporters. Yeah. Metformin reduces fasting plasma glucose and insulin levels, improves the lipid profile, and promotes weight loss. So metformin is effective as a monotherapy and can be used in combination therapy with other agents or insulin, as we have already discussed. Long-term use is associated with reduced micro and macrovascular complication of diabetes. The major toxicity of metformin is lactic acidosis, which is very rare and can be prevented by careful patient selection. Like we avoid metformin in patients of renal failure, cardiac failure, or liver failure. Metformin reduces vitamin B12 levels. So vitamin B12 levels are lower during metformin treatment and should be monitored. Metformin should not be used in patients with moderate renal insufficiency, that is GFR less than 30, any form of acidosis, unstable CHF, liver disease, or severe hypoxemia. Because in these cases, there is increased chances of lactic acidosis in a person taking but one. Then another class of non-secretagogues is thiazolidinediones. Okay. They reduce insulin resistance by binding to PPR gamma nuclear receptor. The PPR gamma receptor is found in adipocytes and it can be found in many other tissues. Agonists of these receptors, that is thiazolidinediones, regulate a large number of genes. It promotes adipocyte differentiation and reduce hepatic fat accumulation, and further promote fatty acid storage. Circulating insulin level decrease with the use of thiazolidinediones, so they definitely reduce insulin resistance. The drugs in this group are rosiglitazone and pioglitazone. They are associated with weight gain and reduction in the hematocrit and mild increase in plasma volume. This is very important point that peripheral edema and CHF are more common in individuals treated with these agents. So these agents basically decompensate any heart disease that is produces peripheral edema and CHF. That's why these agents are contraindicated in patients with hepatic insufficiency or CHF. Okay? So they can decompensate that CHF or they can worsen the patient. According to a FDA review, pioglitazone may be associated with increased risk of bladder cancer, although it is not proven, but generally we avoid it in patients having increased risk of bladder cancer. Then another class of drug in this group is SGLT2 inhibitors, and they are a wonderful class of drugs. Okay? They have emerged as a very good treatment. So basically what they do is they lower the blood glucose by selectively inhibiting SGLT2 transporter, which is expressed in the proximal convoluted tubule of the kidney. Now suppose this is proximal convoluted tubule and we have this sodium and glucose transporter here. So suppose this inhibit this. Okay. So what is the purpose of this SGLT2 is it will reabsorb the glucose. So definitely it would decrease glucose reabsorption. So this inhibit glucose reabsorption, lowers the renal threshold for glucose and leads to increased urinary glucose excretion. So there would be increased excretion of the glucose in the urine, leading to decrease in the blood glucose level. Thus, the glucose lowering effect is insulin independent and not related to changes in insulin sensitivity or secretion. The one drawback of this drug is the loss of urinary glucose may promote modest weight reduction. The drawback is due to increased urinary glucose, urinary and genital mycotic infections are more common in both men and women. So basically, they increases the chance of UTI. Clear? And since these agents also impair proximal reabsorption of sodium, their use is associated with a diuretic effect and 3 to 6 mmHg reduction in systolic BP. Okay? Now, inhibition of SGLT2 may lead to increased glucagon and consequently liver production of glucose and ketones. So, since they promote ketones production, euglycemic decay may occur during illness or when ongoing glycosuria marks stress-induced requirement for insulin. So basically, they increases the chance of euglycemic decay. The drugs in this group are empagliflozin or canagliflozin, and it reduces cardiovascular disease events and cardiovascular mortality in patients with type 2 diabetes. All SG2 inhibitors may reduce hospitalization for CHF. So they are the preferred drug in patients of diabetes along with coronary artery disease. Empagliflozin, canagliflozin, and dapagliflozin, they all have been shown to reduce progression of diabetes kidney disease, but they should not be initiated in patients with stage 3B CKD, that is EGFR less than 45, and should not be used in patient with stage 4 CKD, that is EGFR less than 30. There may be a possibility of increased risk of bladder cancer with dapagliflozin. But overall, SGLT2 inhibitors are a wonderful class of drugs as the diabetes is mostly associated with CAD and they reduce cardiovascular mortality in the patients. Now, DPP4 inhibitors. Basically, DPP4 inhibitors inhibit degradation of GLP-1 and GLP-1 is an incretin. So, GLP-1 increases the production of insulin and DPP4 inhibitor inhibit degradation of GLP-1 leading to increase in the level of GLP-1 which further leads to increase in the insulin level. So it promotes insulin secretion in the absence of hypoglycemia or weight gain and appear to have a preferential effect on postprandial blood glucose. They are used either alone or in combination with other oral agents. Reduced doses should be given in patients with renal insufficiency. Allergy, including rash, hypersensitivity reactions, and severe joint pain have been reported in association with DPP4 inhibitors. There is evidence concerning a potential increased risk of acute pancreatitis with GLP-1 receptor agonist and DPP4 inhibitor. So they are generally avoided in patients with acute pancreatitis or increased risk of acute pancreatitis. Okay. Examples are vildagliptin, linagliptin, saxagliptin, and etc. Then we have this class of drug known as alpha glucosidase inhibitors. The drugs in this group are acarbose, voglibose, etc. They inhibit or reduce postprandial hyperglycemia by delaying glucose absorption. So basically, they delay the absorption of glucose. They do not affect glucose utilization or insulin secretion. Postprandial hyperglycemia, secondary to impaired hepatic and peripheral glucose disposal, contributes significantly to the hyperglycemic state in type 2 DM, and this drug affect that part. Okay. These drugs taken just before each meal. So most of the time their doses are TDS. This is thrice a day before every meal, and it reduces glucose absorption by inhibiting the enzyme that cleaves oligosaccharides into simple sugar. Basically, they inhibit the conversion of oligosaccharides into simple sugar, thereby inhibiting the absorption. Their major side effect is diarrhea, flatulence, abdominal distension due to increased delivery of oligosaccharides to the large bowel. Okay. These agents should not be used in individuals with inflammatory bowel disease, gastroparesis, or serum creatinine of more than 2. This class of agent is not as potent as other oral agents in lowering the HbA1c, but it is unique in decreasing the postprandial glucose rise. One of the important thing is if hypoglycemia from other diabetes treatment occur while taking these agents, suppose a patient is on insulin along with acarbose, and if the patient have hypoglycemia attack, then the patient should consume glucose only, because if he or she will consume complex carbohydrates, these would not be broken down into the glucose due to these drugs. So if there is any hypoglycemia attack in the patient on alpha glucosidase inhibitor, they should be given glucose only. Now we have discussed oral agents. Now we have injectables. First one is GLP-1 analogues. As we have already discussed, that GLP-1 is an incretin and it amplifies glucose stimulated insulin secretion. Okay. So agents that either act as GLP-1 receptor agonist or enhance endogenous GLP-1 activity are given. Okay. Agents in this class do not cause hypoglycemia because it is glucose dependent. Okay. So whenever we take glucose, then only there is GLP secretion. Okay. They increase glucose stimulated insulin secretion, suppresses glucagon, and slow gastric emptying. These agents do not promote weight gain. In fact, most patients experience weight loss with them. Short-acting GLP-1 receptor agonists are exenatide, liraglutide, and lixisatinide. Long-acting ones are sustained-release exenatide, dulaglutide, lexisonide, and semaglutide. Yeah. Daily oral semaglutide is now available that depends on gastric absorption to avoid proteolytic degradation in the small intestine. Okay, so we have already discussed the GLP-1 analogs are injectables except this semaglutide, which is also now available as an oral drug. Now, higher doses of liraglutide and semaglutide then used for glucose lowering effects are now used for weight loss in therapy. Here, liraglutide treatment has been associated with decrease in cardiovascular disease events in patients with type 2 DM and established cardiovascular disease and with lower rates of decay. Okay. Semaglutide treatment has been associated with fewer cardiovascular disease events and reduced diabetic kidney disease, but with an increased rate of retinopathy related complications. While dulaglutide treatment has been associated with both reduction in CVD events and in composite microvascular retinopathy and nephropathy related complications. Now, the major side effect of GLP-1 analogs are nausea, vomiting, and diarrhea. Some formulations carry a black box warning from the FDA because of the increased risk of thyroid cell tumors. Is a very important question in rodents and are contraindicated in individuals with medullary carcinoma of the thyroid or men. So someone is having MEN syndrome, then we avoid these drugs because there is a increased risk of thyroid cell tumors. Then we have another class of drug in injectables. These are amylin analogs. They decrease gastric emptying and decrease the level of glucagon. The drug in this group is pramlintide. It reduces postprandial glucose level and it promotes weight loss. Side effect is nausea and increased risk of hypoglycemia along with insulin. This is the only drug that can be given in type 1 DM other than insulin. Then we have these insulin preparations. In insulin preparations, we have this rapid acting insulin whose onset of action is 10 to 15 minutes and peak time is 60 to 90 minutes. Example in this is insulin lispro and insulin aspart. They are mostly given as a bolus, usually right before eating to lower high blood glucose. Then we have short acting ones whose onset is 0.5 to 1 hours, peak is 2 to 4 hours, in which we have this regular insulin. It is also given as a bolus and it is normally taken 30 minutes before meal. Then we have intermediate acting whose onset of action is 1 to 3 hours and peak is 5 to 8 hours and duration is almost up to 18 hours, in which we have this NPH insulin. It is mostly given as a basal dose and mostly it is often taken at bedtime or twice a day. Mostly we used to give them twice a day. Then we have extended long-acting analogs whose onset is 90 minutes. There is no peak, so they generally don't cause hypoglycemia by themselves. And duration is 24 hours. So they are mostly given once in a day. Examples are Lentus or Glargine and Betamir. Yeah, they are mostly given as a basal dose. Then we can have pre-mixed insulins. Okay. So in pre-mixed, we can one short acting and other one intermediate or extended long acting. And they are in pre-fixed ratios like 30-70. The most common ratio we use is Mixtard, which contains 30-70 of regular insulin plus NPH, which 30% is regular and 70% is NPH, and it is given twice daily. Now complications. So we have acute complications of diabetes like hypoglycemia due to insulin or secretagogues. So whenever we start any patient on insulin or secretagogue, we should warn them about the signs of hypoglycemia and immediate response that they should take in case of hypoglycemia. Then another complication in decay that we'll discuss in detail later on. And the second is HHS. Yeah. Then chronic complications of diabetes. Chronic complications, we can have macrovascular complications like coronary artery disease, and another one is peripheral vascular. Okay. And in microvascular, we have this diabetic retinopathy, diabetic neuropathy, and diabetic retinopathy. Okay. So basically, all of the tables and text is taken from Harrison 21st edition. So let us take a quick review of what we have discussed. First of all, we have discussed that diabetes is basically any disorder leading to hyperglycemia. Then we have discussed types of diabetes, type 1, type 2, gestational, and monogenic forms of diabetes. Then we have discussed the symptoms, 3 Ps, then how insulin is secreted. Basically, there is this role of ATP sensitive potassium channel, and on this channel, drugs act. Then diagnosis, and we have discussed that what is the comprehensive medical care for individual with diabetes. Then we have discussed the treatment goals. What is the treatment goal for non-pregnant adults and what is the treatment goal for high risk adults. We have discussed that how the treatment should progress in a case of type 2 diabetes. Like first we should do a medical nutrition therapy and metformin. Then if it is not controlled, then we should add second agent. And if it is not controlled, then we should add third agent or insulin. Yeah. And we have discussed the drugs. In insulin secretagogues, we have sulfonlyureas, meglitinides. In non-secretagogues, we have biguanides like metformin, very important. Then thiazolidinediones, in which we have rosiglitazone and pioglitazone. Then SGLT2 inhibitors, wonderful class of drug. But their major complication is UTI and euglycemic decay. Then DPP4 inhibitors, again wonderful class of drug, but they are associated with pancreatitis. Then alpha glucosidase inhibitor, again good class of drug. Basically, the important thing about them is they leads to diarrhea, flatulence, and abdominal distension. They are contraindicated in patient of IBD, and if any patient on alpha glucosidase inhibitors develop hypoglycemia, then the treatment should be glucose only, no complex carbohydrate, no sucrose, no oligosaccharide. Yeah. In injectable, we have GLP-1 analogs. In addition to decreasing blood sugar level, they also promote weight loss. So they are now also used as a weight losing agent. In this class, we have mostly injectables. Semaglutide is now available, which is an oral drug. Yeah. Then we have this amylin analog, in which we have the drug called pamlintide, which can be given in type 1 diabetes too. Then in insulin preparation, we have rapid, short, intermediate, long-acting, and premixed insulin. Now in complications, we have the acute complications, hypoglycemia, decay, and HHS, and chronic complication, in which we have macrovascular and microvascular. Thank you very much.